accessory ligaments. Next question, what do you know about the movement in relation to the axes and planes of motion? And I think probably number 5, the muscles which influence. And I'm talking now probably about the muscles which detrimentally influence the joint, in terms of could they actually make function less efficient by holding the bones in certain positions. So which muscles influence? So I don't want you to try and think of muscles that could produce correction, but things that we may need to stretch out, for example, before we try and do mobilization. So which muscles influence the joint detrimentally? And 6, the nerve supply of the joint. All right, so this is a little group discussion. You've got 10 minutes to answer those things. You don't need to write all the answers down, just kind of brainstorm it, or if you're going to write it down, use that thing of Buzan that you can just start your central thing, paper on the side, blank piece of paper, and just write in enough to remind you of the discussion that you've had with your partners. So let's go back to our first day thing, or perhaps we can't, and sort of sit around the table so you can see each other. Okay, Kathy, would you agree with that? The sacroiliac problem. Yeah. A review of the anatomy, mechanics, and diagnosis by Beale, who was one of the leading teachers at the School of Osteopathic Medicine, East Lansing in Michigan, for a number of years. And it is a problem. Not in terms of our understanding that movement takes place, but in the complexities now that are coming up with all of the stuff with open and closed chain activities and so on. Now then, what I would like to say to you is this, that it's very important that you try and understand, and that teachers that are propounding various ideas actually tell you when it is thought processes that they have had on how things work, as opposed to things that have been really proven in anatomical and clinical studies. And a lot of the stuff that Beale is talking about, he makes the point that many of these things are theoretical concepts of clinicians and have not been backed up by a lot of experimental research. Now, there's no question that a lot of work has been done in the last few years on the sacroiliac joint, and indeed, in spine over the last 3 years, there's been at least 3 or 4 articles on the sacroiliac joint. And there was a very big and prestigious meeting on the sacroiliac joint in San Diego, organized by Vlemming from the Netherlands and by Vert Mooney, to look at the sacroiliac problems. And I don't know whether this helped very much in consolidating what we know and what we think about and what we guess about. And so this is the big problem. And so anybody talking to you about this thing are going to have differences with other people. So that's the starting point, okay? What I would like to say is this, and I think this is a fairly moderate approach to sacroiliac dysfunction, as described by Greg Grieve. And I do the same thing on manipulation courses as on this mobilization course. I bring these points up because I think we need to go back to things that don't seem to be too controversial here. And I think that's absolutely a reasonable way of looking at it. The joint is a part fibrous and a part synovial joint. So it's kind of an interesting joint there, and we can talk about that. And when we're talking about dysfunction, we can get a hindrance of movement at some point on the limited range of movement, which is usually reversible. In other words, we can correct it. We can get fixation at the limit of range, which we can also correct. Irritability in this joint can be at times severe. It does suffer from arthritic problems, acute arthritic problems. There's a tendency to hypermobility when adjacent joints become stiff. It's part of the HPL complex, the lumbar spine, pelvis, hip. And dysfunction in any of those areas is going to be reflected in some sort of compensation in one of the other joints. It can get arthrosis and arthritis, and Vleming has done some excellent work on the arthrosis part of this joint, and I'll mention one or two of those points later on. We can get involvement with diseases of the adjacent bone, and we can get instability due to ligamentous laxity. Now, I don't think that is a controversial set of statements in any kind of modern group. That seems to me to fit where we should be going. Yes. I thought you wrote shorthand, Kent.
This is from Grieve?
Grieve's book, yeah. He wrote an excellent article on sacroiliac joint dysfunction a number of years ago. And it was very kind of uncontroversial, I think, as opposed to what a lot of us think now, which might be a bit more controversial, because I think a lot of it is very, very speculative. Okay? Now, next thing. Have a look at these two pictures, all right, which illustrates the same thing. The top picture is by Kramer, found in Levitt's book. The bottom picture is a simpler form and found in McNabb's book. And McNabb wrote an excellent book which has now been updated into a second edition on backache. McNabb was one of the most prestigious orthopedists in Canada. He was trained in England with Charnley, and then he came to Canada. He did some excellent research work on tendonitis of the shoulder. It became a classical article in the Journal of Bone and Joint Surgery and so on. And he wrote this book, which was most interesting. It was a kind of a formal book that came from a set of notes that he produced for the Workers' Compensation Board in Ontario. And the book came out and it didn't have a single reference in it. You know, so in North America, if your book isn't, you know, at least half the thickness of the book is in references, whether they mean anything or not, but it gives you an air of knowing what it's about, doesn't it? An air of validity if you've got all these references, because you know nobody's going to start looking back into all of these references anyway. And sometimes when you look at the references, you can't find the bit in the book that this reference relates to anyway. So McNabb brought out this book, but McNabb, who was a very conservative orthopedic surgeon, had absolutely no doubt that years ago, when in orthopedics there was a big problem about movement in the sacroiliac joint, McNabb had no problem about whether it moves or not. And indeed, if we go back in Britain to one of the most conservative of orthopedists who wrote one of the great treatises on orthopedic surgery, which was Sir Reginald Watson Jones, He was the one that I think has fundamentally changed how we look at elbow joints, because he said, you know, manipulation of the elbow joints by physiotherapists always make it worse, but you kind of ask what manipulations were being done. And this goes back to prior to the Second World War when he came up with this, you know, just what was done. And so now we still say never manipulate this and that because of those words. But even Watson-Jones, who was very conservative, said that the sacroiliac joint can give patients so much problems that it can convert them into invalids. So this is a very conservative orthopedic surgeon if we go back in history. And that would certainly be at the time when there was a lot of arguments about what would happen with the sacroiliac joint. So I think we don't need to worry about any controversy about its movement or anything now. It's just what the complexities of it is. Now, this picture by Kramer, Greg Greaves said about this picture that it would require a manipulation of heroic proportions to correct this problem. Actually, I think what he's saying simply is that if we get a movement of one joint, there's going to be a relative opposite movement of another joint, and it will reflect itself through the entire pelvic rim. And so we get compensating changes. And if anything happens on this side, and the same thing doesn't happen on that side, then something's got to happen with the sacrum. Whatever it is, and can we measure it, and does it mean much to us, is a different thing. But if we ever get these kinds of things happening and fixing, then somewhere else in the pelvis has got to try and compensate for it. And McNabb, in a simpler way, is saying exactly the same thing, that movements of the sacroiliac joint are going to reflect themselves in changes in the pubis at the front. So here are two sources, both of which are saying the same thing. Now then, here's a set of conclusions here that I think are reasonably good as well. That the range of motion is small and decreases with increasing age. What doesn't decrease with increasing age? 2, the range of motion is greater in women and increased during pregnancy. The motions are coupled. The question is coupled with what? And dependent on some degree of joint separation. So we've got an interesting bone here, which is an aggregation, if we think of the sacrum part of the sacroiliac joint. An interesting thing here in relationship to its relationship with the rest of the spine when it could be thought about as being a vertebra, and then its relationship within the ilia, when it may be able to be thought about as being part of the lower limbs. So it's not quite the same as other vertebrae, although we'll sort of think about how it relates to the upper limb and how to the lower limbs and how it relates to the spine a little bit later on. And then we've got some comment on that the predominant motion is x-axis rotation, so that will be the anterior and posterior rotational movement, coupled with some degree of z-axis translation. So this is going to be movement on a postero-anterior axis, a little translation. So we've got from a fairly thing, I think this is from Punjabi and White's account here, that we are talking about a little of this and a little of that. So we're just sort of totally familiar with these Cartesian coordinates. Okay, here we've got a more straightforward view than we're going to look at here with the x-axis and the z-axis. So we can get that rotation around there and slight forward and backward translations of a very small degree. And I think this is justified, and certainly some of the work that was done by Weissel a long time ago seems to suggest that this is the way that the thing moves. And we'll discuss how that takes place. Okay, so we've got movement, we can get dysfunction. If we get dysfunction, perhaps we can do something to beneficially affect it. So let's think a little bit about the joint surfaces for a moment. Things that you mentioned about the joint surfaces. Okay, I'll sort of go over this, and then If you've got anything else to add on this, then we can sort of all add it to the board. But being as you used your brain for 15 minutes, I'll use mine now. Okay. When we look at the joint surfaces here, we've got this so-called auricular surface. Now, we can kind of divide this into a vertical pole and a horizontal pole. I really don't know whether this really matters if we do it. When we look at how movement occurs anyway, does it really matter? When we look at this, we know that the surfaces are irregular. When does the irregularities occur? Probably at the end of puberty. Prior to puberty, the joint is fairly planar. And then past puberty, the irregularities develop. And we've roughly got congruency. Not exactly, but roughly we've got congruency. So that when we've got an elevation on one of the surfaces, that will coincide with a depression on the other surface. So there's roughly congruency within the joint itself. Now then, what about the surfaces of the joint? What did you come up with there? For what it's worth, the sacral surface is covered by hyaline cartilage, and the ilial surface is covered by fibrocartilage. Now then, the joint surface as we see it here is not the complete joint surface, because we've got to take into consideration also this pitted area behind, because this joint is part synovial and part fibrous. So it's a synovial joint where we see this auricular surface here, and it's a syndesmosis here where we see the pitted area. And this, of course, is the attachment of the interosseous ligament. So an interosseous ligament gives us a syndesmosis. So we've got a very interesting thing here. This is the syndesmosis part, and this is the synovial part of the joint. And we know any time we see a syndesmosis, there's a lot of strength and there's not a lot of movement. And that fits in with our whole understanding of the way that the body goes, generally speaking, that if we've got a lot of movement, it is at the expense of stability. Here we've got some movement, some stability, and this fulfills the role of this particular joint, as we'll see a little bit later on. Now, was there anything else that anybody would like to put in as far as the joint surfaces are concerned? I think at this stage we could talk a little bit about some of the work of Fleming in terms of arthrosis and arthritis and the gradual reduction in movement in relationship to age. Generally speaking, we used to think that because of the work that was done on cadaveric specimens, where we looked at all the arthrosis within the joint, that in men this joint had become fused at the age of 45 to 50, and women at 55 to 60, and that there was very little movement in men after 50 and women after 60. Now Fleming has looked at this in a different way. He's looked at the cadaveric models, or the cadaveric specimens, and he said that although there are fundamental changes of arthrosis within the joint, we're not seeing across the whole of this kind of synovial part here a migration of fibrous tissue. It's becoming more pitted in a more microscopic way, not these major sort of elevations, but sort of almost like, not osteophytes exactly, but little elevations and depressions like that that used to be thought as being examples of so much bone within there that it would mean that they're fused up. But what Vleming noted was that these little elevations and so on were all capped by hyaline cartilage. And he felt that the existence of the hyaline cartilage still suggested that movement was taking place. Whereas if you looked at this purely in an aged specimen with none of this on, you might erroneously imagine that no movement could take place. And so what Vleming has said is that there are age changes taking place in the joint, but because of the existence still over the joint of little islands of synovial or of hyaline cartilage, this still denotes that movement will take place. So what we've done is accepted that it stiffens, but the age of fusion, if it takes place, has now been put a little bit later on in men and in women. And so that's made me feel a little more comfortable. However, I still find that if I have a man of 50 or 55 that I'm finding a sacroiliac joint problem, I still usually go back through my findings, and I don't really believe it until I've done a kind of second little confirmation. Equally well, I think if, 55% of all the patients you see, unless you're a sacroiliac specialist, okay, all of the backs you see, 50-odd% are sacroiliac problems, then you better start looking at the way you're working out how important this is. I think it causes problems, but not to huge degrees of percentage in low back patients. This is a very stable joint. It's very efficient in what it does, even though we do get things going wrong. So those are the points I would make about the movement or about the joint surface. Now, the important things, I think we've got to think about the thickness of the hyaline cartilage on the sacral side of the joint, because this might suggest to us how a joint that is so irregular can actually move. So, let's have a look at the joint surfaces from a slightly different orientation here.
That was Fleming with an F?
Vleming,
Fleming.
with a V. Is it V-L-E-E-M-I-N-G? Vleming? Yeah, okay. He wrote 2 articles, I think I'm not sure it was in the same journal or 2 successive journals in Spine, but it's in the last little while, and it was very, very interesting stuff. They've done a lot of excellent work, actually, in the Netherlands on this particular joint. Okay. Let's just look at this joint now and sort of confound ourselves a little bit. Of course, this is a picture from Kapanji, and it illustrates this point very, very well, which makes us think about all the things we do with this joint and say we can feel that the irregularities are not constant in every part of the joint, and if we take sections through any part of the joint, the congruency of the surfaces is a little different. We get elevations and depressions at different parts of the joint, which means that we've got absorption factors presumably built in regardless of where the joint is. But the problem with this is we don't know what those irregularities are in any person at any given time. And the other problem is we don't know from one person, one side to the other side, whether it's exactly the same alignment. This is the problem with all of this. Dalseth, a number of years ago, challenged the manual therapy group, this is the doctors and so on in Europe, and said, look, I've looked at 1,000 specimens of craniovertebral structure, and I see that nearly 100% of them are different one side to the other. So how can you tell me that testing one way and another way you can make a direct comparison when the structure is asymmetrical? Good question. So that caused a little bit of diarrhea in the manual therapy things in there, so they all got together and met, and now we've come up with the thing, yes. But we're not testing just quantity, we are testing quality of movement. So now we're into the physiological concepts of subjective analysis. So nobody can kind of argue with this one. Here's this picture in a slightly different way, taken from Solinen's work, from Diane Lee's excellent little book on the pelvis here. And we can see that these irregularities, as we see them in different parts of the joint, would seem to suggest, here's one that's irregular. They're quite lucky, they're the same on both sides. Here we've got a different one which shows a different variation, much more of a planar joint, presumably would give far more movement than perhaps would be possible in this joint. But do we know with anybody what we're actually finding, or what the kind of form is that they have that backs up our findings? This is the whole difficulty with this joint. So we've got some problems with it, and let's try and keep away too much from the controversies. Now then, look at the interosseous ligament, and let's just relate that to two of the intrinsic ligaments of the joint. We can see the layout here of the interosseous ligament, which of course is one of the strongest of the body, and here we can see the synovial part of this. And the interosseous ligament is forming at its front edge here the posterior kind of capsular structures of the joint. And here we have the anterior sacroiliac ligament. Obviously this is it's not obvious that it's a weak ligament, but it is but it's obviously weaker than all of this posterior structures. And then behind the interosseous ligament would be the posterior sacroiliac ligaments, and that's what we can see here. So we've got the interosseous, which forms the posterior part of the capsule on its front edge here. We've got the anterior capsular structures and thickening, which is fairly weak, and we've got these posterior ligaments here. And we'll see that nearly all the strength of the joint is posterior, which seems to suggest where the stresses are coming from, because they will be resisting those stresses. So those are the two intrinsic ligaments, the anterior and the posterior capsule. The osseous ligament is an intrinsic ligament. Of course, it's the syndesmosis. It's a fundamental part of the joint. And then probably we can call the posterior sacroiliac intrinsic ligaments as well, as they're the back part of the interosseous ligament. Now then, what are the other ligaments in the joint? What did you come up with? The two main ones, or the three main ones, I guess. The two that are named and could be picked up from that would be the sacrotuberous, which we see on here, coming up to the lateral part of the sacrum, and actually merging up, according to Gray's Anatomy, up as far as the posterior superiliac spine, and the sacrospinous ligament coming from the ischial spine to the sacrum here. Now, if we take, and we haven't argued this point at the moment, but we will, if we take, where would this x-axis be, then there's a little bit of argument, but mostly it would appear to be around about S2. Whether it's right within the middle part of the auricular surface or whether it's behind in the interosseous ligaments really doesn't matter all that much. But if we place it up here somewhere, we can see that these two ligaments here, which are large, this one of course is usually considered to be an upward prolongation of the hamstring, isn't it? Okay? That the motion can be controlled over a relatively long lever. So these ligaments are very efficiently placed